So this, the button's blown out that arrow, but that advances the slides. Okay. And you can either stand here, or do you want to use,
I'll use
this one?
That's okay.
Yep, and it just needs to turn on. That will on, and I'll introduce you quickly. And if you would repeat. Okay. Otherwise, the recording doesn't pick it up. Okay, thank you, Dr. Moore. Our next presentation is on dermatology and skincare by Dr. Yvonne Chiu, and she is a pediatric dermatologist at Children's Hospital of Wisconsin, an associate professor of dermatology and pediatrics at the Medical College of Wisconsin. And she's actually here this weekend for a dermatology conference right across the street. So she ran over to give this presentation, and she has to run back to give another one over there. So it's a good thing we're getting her started a little early.
Great. Thank you so much for the kind introduction. I'm really honored to be here to speak with you. As Cindy just mentioned, we had our Pediatric Dermatology Research Alliance conference just across the street this past weekend. And so it's really inspiring to be there, to be talking about the science and what we can do to advance research in children with skin disease, and then kind of come here and meet with families and children. I'd have to say that the Halloween party last night looked like it was a lot of fun. It was really bumping until pretty late, and we were really kind of feeling sad that we were, you know, in our little auditorium talking about really nerdy things and missing out on all the fun you guys were having next door. So I want to kind of focus a little bit on some of the skin things that might be relevant to you and your children and families. And so I want to summarize a little bit what the topical therapies are for morphea and localized scleroderma. And I'm a dermatologist. I tend to use the word morphea. I know there's a lot of controversy or kind of differences of opinion about that, so forgive me if I slip. And then talk a little bit about what are the cosmetic options for inactive lesions. I feel like this is a question I get a lot from patients. What can be done, what's real and what isn't, and then finally just sort of some general skincare tips, because I think no matter what sort of skin disorder that you have, there's some very foundational basics that applies to everybody. So let's start first with some of the topical therapies. Oops. So in general, topical treatments are used for mild disease, or sometimes we use them in addition to some of the systemic agents that are being used. And there's four main categories of what we use. You use topical steroids, which I think most people are familiar with. It's a category of medications called topical calcineurin inhibitors. There's a group of topical vitamin D creams, and then finally something called Imiquimod. And all four of them have been shown in mouse models or basic science studies to decrease the fibrosis and decrease the amount of collagen that's being produced, so therefore they soften the skin. And then 3 of the 4 have been shown to decrease the inflammation that might drive scleroderma. So the most commonly prescribed topical medication are topical steroids, and what's surprising is these have never been studied in any formal research kind of trial. Topical steroids are just part of the dermatologist's arsenal. We prescribe them all the time, yet there's really not any scientific data to say how effective they are in scleroderma. But based on personal experience, we know that it works. Examples of different ones that might be used would be things like clobetasol, halobetasol, betamethasone, and then fluocinolone. And so just to understand, we have 7 categories of topical steroids. The high potency ones, the ones that are at the top of that list, class 1 or class 2 topical steroids, are going to be the ones that work the best, and they're the ones that we probably prescribe most often. So those are the names that you're seeing there again, clobetasol, halobetasol. As you go down to class 7, those are decreasing strength, the topical steroids. So like hydrocortisone that you buy over the counter, that's there at the bottom, class 7. Now the main problem with the topical steroids is that even though they work very well, they can cause side effects, and the main side effect that we see is this risk of skin thinning. And when I talk about skin thinning, everybody freaks out and they worry and they're not exactly sure what that means. So here's a picture showing what can happen in the early stages of skin thinning if you use a topical steroid. So you can see that on this arm, and I'm sorry, I don't know if this, there's a little bit right here where you see some of those fine purpley blood vessels starting to show through a little bit on the skin. And then even the bluer, deeper, bigger blood vessels are a little bit more noticeable. And so that's what we say when we say skin atrophy. With a strong topical steroid like clobetasol, class 1, that can occur and start to happen within about 6 to 8 weeks of starting that topical steroid. So that's why it's really hard for us to use these topical steroids long term in treating kids who have localized scleroderma, because one of the disease kind of sequelae, or one of the after effects of localized scleroderma, is that it can cause skin atrophy. So oftentimes we find ourselves in this situation where, is this the topical steroid that's doing it, or is this the disease that's doing it? And so therefore, we really try to limit the use of these strong topical steroids to no more than 1 or 2 months. This side effect is reversible. So if you see this happen and you stop your topical steroid, this skin will go back to normal, usually within a few months. So it's not the end-all be-all if this happens, but obviously we want to try to catch it at this early phase before you start to develop some of the irreversible side effects like stretch marks. And everybody's familiar with what stretch marks look like. And so when that happens, we can't reverse that. So then we go on to other medications beyond topical steroids that can be helpful. And so this is where your topical calcineurin inhibitors and topical vitamin D comes in. The plus side of these is that they don't cause skin thinning. So you could use them forever and you're not gonna have side effects of skin thinning. You don't have worries about complicating the picture. The negative side is they just don't work as well. They're not as strong of an anti-inflammatory, anti-fibrotic. So a lot of times what you may be seeing people do, or depending on who your doctor is and which dermatologist is treating you, oftentimes we'll do something like a strong topical steroid for a month or two, wanna see the kids back, and then we might then go on to using something else that's steroid sparing as more of a long-term maintenance therapy once you've knocked down some of that initial inflammation and skin hardening. So there are 3 different types of topical calcineurin inhibitors. You've got 2 different strengths of tacrolimus ointment, the 0.1 and the 0.03. And then there's another one called pimecrolimus, or Elidil is the brand name of that one. And these are thought to be decreasing in strength. One of the other cons about these is these aren't always well covered by insurance companies. So depending on your insurance and what drugs they have on their formulary, these may or may not be covered. They're extremely expensive if purchased out of pocket. They're usually several $100s for a small tube. And so it can be challenging sometimes to work with individual patients and their insurance to find something that is covered. So sometimes instead of a calcineurin inhibitor, you may then see us use something like topical vitamin D. So again, steroid sparing, no risk of skin thinning. It's an alternative to consider. And we use these 2 just depending on what your insurance will cover. I might try to prescribe one, insurance doesn't cover it, let's try the other and see what we can get. Vitamin D comes in 2 different forms. There's a calcitriol and calcipotriol. Those are very similar molecules, and we think that they work pretty similarly. And then there's a very nice form of topical vitamin D that comes with a topical steroid built into it. This is technically FDA approved for people who have psoriasis, which is like an inflammatory skin disease with red scale. But oftentimes we can use that for morphia as well. But you have to be careful because again, the topical steroid in there, you don't want to be using this long term. And then there's a drug called Imiquimod, and Imiquimod is very interesting. It comes in these little tiny foil packets, and Imiquimod is initially FDA approved for genital warts. And you think, well, what does genital warts have to do with localized scleroderma? And it's really interesting because the way that Imiquimod works in treating genital warts is it stimulates your immune system and stimulates inflammation so that your immune system can kill that virus and get rid of those genital warts. So you would think that it's a little counterintuitive, like why would this work for morphia? But what's also been shown in basic science studies, and it's also been shown in a small trial in kids, is that it softens the skin. It inhibits that fibrotic pathway that leads to that skin hardening. So it can oftentimes be very helpful for some of the harder or thicker lesions where maybe you're not really having a lot of inflammation anymore, but you're trying to soften that skin out again so it's not as hard. And there's an example of that right here with this sort of white center. This would be a really great area to put some of the Imiquimod on to get a little extra benefit. Question?
My daughter has calcifications in her fingers and on her knee. Most doctors don't know what to do with it, and the dermatologists they say just let it be. I wonder if something like a lotion like that would be helpful.
Yeah. Yeah, and I apologize. I didn't include as much about systemic sclerosis and the ulcers and calcifications, but there are actually definitely treatments for that. Yes?
Could you repeat the question?
Oh, I'm sorry, thanks. So the question is what we can do for calcinosis in the fingertips and in the knees. I think we see that more often with the systemic sclerosis patients. I don't have slides on that, but I can tell you that there are some treatments that we dermatologists are doing. There is something that's called sodium thiosulfate that I've had some good success with. Sodium thiosulfate is typically given as an IV drug, and it has been used for a long time in the dermatology world to treat a disorder of calcification that's called calciphylaxis. You can make sodium thiosulfate into a cream. You'll need to find a special compounding pharmacy that will do it. They can make that into a cream, and then you can apply it to small areas of calcification twice a day. And I've had some good success if they're small. And then from there, sometimes what you can do, if that doesn't work, is you can inject the sodium thiosulfate into the areas of calcification. And the reason why we try to avoid the IV form is that comes with major side effects, usually causes a lot of nausea, and so we avoid that. But used either as a cream that's specially prepared by a compounding pharmacy, or as small local injections into the area of calcification, I've had good success with that. Good question. Other questions? Yes? Mm-hmm. Would that be helpful to protect the environment? I don't think so. I don't think there's a lot of data on topical vitamin C. Studies have shown vitamin C is very attractive for like anti-aging effects. So you'll see a lot of like these anti-aging creams and antioxidants talk about vitamin D. The problem is that any vitamin C that you apply to the skin immediately starts getting oxidized. And so when that happens, you actually don't get any durable effect of it in the skin. So it's very popular in all those creams. Everybody likes it because vitamin C is an antioxidant, but in reality, it doesn't last once it's applied. Okay. And I left plenty of time for questions. I don't have a lot of slides, so I welcome a lot of interaction and whatever questions you guys have. Feel free to stop me at any time. So let's talk a little bit about cosmetic options for patients who've got inactive localized scleroderma. I think your three options are cosmetic camouflage, soft tissue fillers, and then surgical excision. And I'll go over each of those in detail. I think the main thing you have to keep in mind with any of the fillers and surgical excision is that a lot of us who treat kids with this disorder feels that there's a role for trauma in potentially triggering or exacerbating disease flares and further inflammation in the skin. And so many people do recommend that if you're gonna be doing something where you're gonna be poking, prodding, cutting that area, that you wanna really make sure that your localized scleroderma is inactive and really kind of hasn't had a disease flare in several years before you try to attempt one of these. And even then, we don't have a lot of research to show, do we have a risk of triggering disease in kids once you start doing some of these more surgical procedures. So here's an example of camouflage makeup. And camouflage makeup is different. These are usually more highly pigmented, much more long-lasting makeup blends. They're a little bit more similar to like theatrical makeup or what they would use in Hollywood, but there are several brands that specifically target using medical camouflage to treat various medical disorders. And so one of the brands, for example, that's most well known is Dermablend. Some of these may require doctor's prescriptions, but many of them don't. And this is an example of our girl who has morphea, where you can see that it's left behind hyperpigmentation. And with some makeup over it, she is able to mask the appearance of that, and it's not as visible. Here's a couple more examples, not specifically of morphea, but you can see in the top left, there's a girl with a burn scar. Again, with high quality medical makeup, you can achieve a look where it's not immediately visible to somebody who's not looking carefully. And then the bottom right is a girl who's got a bright red port wine stain. So again, really kind of helping some children. I don't think this is for everybody, but if you have people who are self-conscious about it or who don't want their signs of disease to be noticed or visible, this is a very good option. Questions? Okay, and then let's move on to soft tissue fillers. So there are a variety of soft tissue fillers. You see the commercials on TV all the time, right? Get rid of your wrinkles, fill them in, look 20 years younger. This is all the stuff that's used for the aging face. The downside with these is these are never covered by insurance. I think, unfortunately, you're not going to be able to get them paid for. If anyone's had success with that, I would love to hear it. If there's a convincing letter or appeal that you've made to insurance companies. So the different fillers that you have, hyaluronic acid is the most common. This is a soft gel-like substance that's naturally occurring in the skin. So you're basically taking something that's normally there in the skin and you're replacing it. The downside of it is it's got a shorter duration, 6 to 12 months. And then you pretty much have to go back because that hyaluronic acid has been degraded and absorbed. Calcium hydroxyapatite is basically these tiny little calcium microspheres that are then suspended in a gel. So because you have these little calcium balls in your skin, it lasts longer. Crazy thing is these will show up on x-rays. So it's really funny. They'll look like you have tiny little pellets in the skin. That lasts longer, closer to 12, the full 12 months. Poly-L-lactic acid is another substance, and what this actually does is it induces your body and your skin to make its own collagen. So because you're stimulating collagen production in the skin, you get up to 2 years of effect. And then polymethyl methacrylate is a permanent microsphere that lasts in the skin forever. It's suspended in a gel substance, and it'll stay there and last in your skin. And then finally, autologous fat. You can take liposuction from the stomach and from the thighs. Plastic surgeon can harvest that, spin that down, and then re-inject that into areas of the skin. Nice thing about that is it's your own body's fat. It can last from months to years. What are the downsides of some of these fillers? They're expensive. So one set of injections, one syringe, is usually about $1,000, $500 to $1,000. And for a large and coupe de sable, it may be several syringes per treatment. And then you're talking about repeating that every 6, 12 months or so, depending on what you use. The ones that are permanent, everyone goes like, well, why wouldn't I just choose the more permanent options? And that's because they have more side effects. And you have to be a little bit more experienced of an injector to get that, to get those right. Because if you inject those too superficially in the skin, you can imagine you've now got these little tiny like pellets, BB balls kind of like in the skin, and they're visible. So they have to be injected by somebody just deep enough so that they're not visible, but also superficial enough so that you can actually get some benefit from them. It's not like buried deep into the fat. These are not done by most pediatric dermatologists. These are not done by most medical dermatologists. So we'd have to work closely with you to find a cosmetic dermatologist or plastic surgeon who would do these. And you'd want somebody who is got some experience. But here's some case reports from the literature. This is somebody who used PMMA, polymethyl methacrylate, the permanent form, underwent 3 injections of that over time. And you can see this is going to be permanent improvement, this in coupe de sable ECDS lesion right here. That's kind of filled in pretty nicely. Here is an example of someone who underwent surgery to remove the depressed area. So in this case, what the plastic surgeon did, and I'm sorry, I'm going to kind of focus on this side, is excise this whole area of atrophic skin, cut it all out, pulled everything together, and so you can see a series of these zigzag scars on the forehead. And so basically, in this case, there wasn't much bony depression, but mostly skin and fat depression that they were able to remove and cut close. Again, I would just say, caution that in something like this, I would just be super worried, really make sure that this child has not had active disease for a long time, because I would hate to trigger something worse. And then this is an example of fat grafting for Parry-Romberg. So fat grafting is a little different from autologous fat transfer, where I talked about you suck some fat out with liposuction and then you spin it down and inject it back in. Fat grafting actually means doing a surgical cut, harvesting an entire lobule of fat with its own blood supply, and then grafting that back in and connecting blood vessels together to make sure that that fat stays there long term. And here's a woman who has Parry-Romberg of the lower face who underwent fat grafting to kind of fill in that depressed divot there. Question?
What's your opinion on if someone has the corticosteroid and the Parry-Romberg? I know there's some confliction. There's a plastic surgeon in Wisconsin that does it while it's active, thinking that you're taking the healthy tissue and replacing it, from the sick tissue. Is that risky or scary to have Parry-Romberg and the scleroderma when you're surgeon?
Yeah, so the question is what I think about doing surgery for active disease, either in coupe de sable or Parry-Romberg.
I feel pretty strongly about this. So there are different things when we talk about plastic surgery for the condition, so linear scleroderma of the head includes the coupe de sable and the Parry-Romberg. So fat grafting is kind of the one slide that Dr. Lee was showing with the fat grafting is literally what that is just like with women get like the lymp enhancement. It's just taking some fat from your belly or your butt. spinning it down, purifying it, and putting it just in little tiny like droplets on your face. So it's a pretty non-invasive procedure. It's more for cosmetic, purposes, and we usually do that kind of after treatment with methotrexate, steroids, et cetera. Disease is quiet, just to kind of, help the patient if that will make them kind of feel aesthetically, better. And we've had good outcomes with that. There's really not a big downside. It's a very well tolerated procedure. If it reabsorbs a little bit, that's the only downside. So, but you need to know the terminology. So fat grafting is just what I was describing. It's literally just the liposuction, spinning it down and putting back in. It's really not invasive. It's like tiny little, you can't even see the scar where, the plastic surgeon goes in. So the more aggressive approach would be flaps. So they're actually flaps like from your back skin and sometimes still attached on a pedicle, and they move it, towards your face. So it's all layers, not just fat and skin, but muscle, fascia, et cetera. Or they'll take that clump out of, your back and free flap. So disconnect the blood vessels and then put that again on your face. That is a very aggressive, very involved procedure. It is appropriate for certain people. So I'm not saying it's not appropriate for everyone, but just certain people, like very severe disease. I think, agreed later after treatment, not like in active disease. I know that I personally have seen patients where I felt they had more mild to moderate disease, and I felt like systemic therapy first would have been a better way to go, and then maybe do fat grafting. Maybe they didn't need the whole giant flap procedure. It's a very involved procedure.
And my comment too, and I would be interested in your thoughts, is I am worried that you're taking somebody where we think trauma or inflammation or drives this disease, and you're putting them through more trauma and more inflammation.
Right.
And
so just please see a peds derm or peds room before you see that individual. We're more than happy if you see, but you need to have medical management as well.
Yeah.
And then I'll let you talk.
I think it's going to be dependent on where you are, because I think a lot of the things that I'm talking about, like these type of injections, and maybe to a certain extent, just like excising a localized area that's been really, really burned out for a really, really long time. I think any good specialist in your local area could probably do that with guidance from your medical doctor, dermatologist, rheumatologist. Somebody can guide you with that. I think something like this, I would be a little bit more, wary about making sure we help you find the right person. But I think you don't have to travel across the country to find somebody. I think you can find somebody in your local community with guidance from who you see. I would make sure that you are seeing board certified specialists. So there are a lot of people out there now who are not dermatologists, who are not plastic surgeons, and then facial plastic surgeons who are board certified in ear, nose, and throat surgery, otolaryngology. Those are the 3 subspecialties that really have training built in during their residency to do cosmetic procedures and cosmetic surgeries. It's very popular now where you go to this local strip mall and you find somebody who's got a laser hair removal place and a Medi-Spa, and you find out who's staffing that place, and it's not even a physician. That some doctor who is not board certified in any of those 3 specialties is just supervising a group of nurses there. And the nurses are the ones doing the injections, and that's what I would really caution you against. But I don't think that it has to be a name of, like you don't have to fly to New York, or you don't have to go to LA to find somebody. You want to find somebody who is comfortable doing these cosmetic procedures, but also understands kind of the medical aspects. And I think that's something where a phone call from me to that plastic surgeon to kind of talk things over would be very beneficial. Okay, question in the back there? Yeah, so if I'm hearing the question correctly, what I understand is your neurosurgeon has counseled against some fillers, but maybe mentioned that for the bone atrophy that there might be a foam. Is that correct?
Did you say bone?
Or what did you say?
Oh, I don't know the terminology. It sounded like he said that they can actually like regenerate bone.
Oh, regenerate bone. I don't know of bone regeneration. I do know that there are some bone substitutes that are like foams. Or maybe he's talking about bone grafting, like you take bone from another part of the body and you graft it into that area. I think that's a pretty invasive, big procedure. I'm not sure that would be necessary. I do know of neurosurgeons and craniofacial, like plastic surgeons, who will sometimes do something for somebody who's got like a skull defect. Not usually morphia, but like something else where they can do a sort of injectable foam type of thing that then hardens and turns into like a bone substitute. But I'm not heard of regenerating bone at this point in time. Okay, was there another question here?
Yes. So my question is that with like juvenile linear scleroderma, you have the red around it, and you know that it's active. How do you know when the ones on the face or the Parry-Romberg has burnt out since there is no red?
That's like the perfect question. So how do we know when localized scleroderma is active, and how do we know when it's burnt out? And it can be challenging. It can be hard. And I think you've kind of asked the million-dollar question that I wish we had a better answer for. I think time. So sometimes if you have a lesion that's deep, you got somebody who's got something like this where there's no signs of disease activity, but you can kind of see that there's just this depression there. Sometimes if you've monitored them for a year and you don't see it getting worse, or 2 years, you can then say it's inactive. But if you walk into my office and you have one time point and I'm looking at this, I can't tell you for sure if it's active or inactive. So I think that's a good question. Yes, question here.
My daughter has with the calcifications, there's also like pitting a little bit with fingers, and the fingertips are actually shortening with the lack of blood flow. And one of the other moms had mentioned last night at the party, possibly like platelets or something. Are they injecting into the fingertips or something to help regenerate tissue or anything like that?
Maybe what you're hearing is something called platelet-rich plasma, which is the latest hot buzz in the cosmetic world. Platelet-rich plasma is taking someone's own blood, spinning it down, and then concentrating your own plasma, which is like the liquid part of your blood, and concentrating the platelets in that, and then using that for a whole variety of things. But the problem is it's not FDA regulated. It's a very lucrative thing for doctors to do because they make a ton of money off of that, and there's no evidence that any of it works. So it's used for anti-aging, it's used to regrow bald men's hair. You see it advertised everywhere, and I think that might be what you're hearing about platelet-rich plasma. I can't say I've seen evidence for that, to heal ulcers. I mean, well, it's been used for like ulcers of other kinds, and perhaps there's some benefit in those areas, but I can't say I've heard of it used for systemic sclerosis ulcers on the fingertips. Great. So then the last topic, and I really appreciate the question, so feel free to stop me anytime and keep them coming, is just sort of general healthy skincare tips, right? Everyone always looks at a dermatologist and goes like, what do I do to get perfect skin? And here's what I'm going to tell you. It's very simple. The main things that we always want to make sure you guys do is sun protection. We know that UV light in some forms is used to treat localized scleroderma and morphia, but we also know that a lot of people who have morphia have this dyspigmentation, right? Your disease is burnt out, but you've got these brown marks left behind on the skin. And the number one rule is that anytime you have discoloration on the skin, whether it's lighter or darker, when you get sun exposure, those differences are going to be amplified and highlighted. So darker skin gets darker, and your normal skin doesn't tan as much. And so everything's going to be much more noticeable in the summer. So sun protection is an essential part of that. And when we talk about sun protection, there's 4 main tenets of it. Number 1 is you want to avoid midday sun. So don't go out between 10 a.m. or 4 p.m. Or not go out, but don't plan to go outside and have your picnic at 11 a.m. in the morning. Do a late afternoon, 4 p.m. picnic with the family kind of thing. Seek shade. So if you're outside on a really sunny day, go underneath a tree. Bring along one of those tents when you're out tailgating so that you can have a place to go underneath the shade. Sun protective clothing is an important part of that, hats, long sleeves, and then sunscreen. So I think one of the greatest things for us as dermatologists in the last 5 or 10 years is that there's been a huge boom in sun protective clothing. You can find these anywhere now. LLB, Land's End, Amazon. It used to be that you only bought them from like these really uncool looking like suppliers, and now it's hit the mainstream, and you see a lot of really cute options for kids. So in the picture on the left, the kids are wearing sun protective wide brimmed hats, as well as long sleeve sun protective clothing. A lot of these clothes will be marked UPF 50 or higher. UPF is like universal protection factor, UV protection factor. Basically just means that this is equivalent to an SPF 50 or higher sunscreen. A lot of really cute swimsuit options too, like in the kids on the right. And then when you're looking for sunscreens, you want to look for a broad spectrum SPF 30 or higher water resistant sunscreen. So in terms of reading a sunscreen label, number 1 at the top, you want to make sure that it says broad spectrum. Broad spectrum means it protects against both types of UV light. Then the next thing is you look at the SPF factor. You want it 30 or higher. You want the sunscreen to say water resistant, and sunscreens are categorized either water resistant to 40 minutes or water resistant to 80 minutes. And so it just means how long it'll last on your skin while you're sweating or swimming. The number 4 you can kind of ignore. I borrowed this from the Skin Cancer Foundation website. They're obviously trying to promote those that have been officially approved. And then number 5 is you want to look at the active ingredients in that sunscreen. So there's 2 types of sunscreen ingredients, just so you understand. There's physical sunscreen ingredients and there's chemical sunscreen ingredients. And what physical sunscreen ingredients are is they reflect and they scatter UV light. So they physically prevent the UV light from penetrating your skin. And these are good for protecting against UVA and UVB lights. And the examples of those ingredients would be like titanium dioxide or zinc oxide. Chemical sunscreen ingredients absorb UV light. So instead of actually reflecting it off the surface of your skin, they take that UV light and they undergo a chemical reaction on the surface of your skin to turn that UV light into different wavelengths. And this is better at protecting against UVB than it is UVA. And then examples of those would be like oxybenzone, avobenzone, and PABA. And so why is it important to protect against UVA? Well, number 1, a lot of photosensitive skin disorders like systemic lupus, dermatomyositis, we don't really think that that's the case with localized scleroderma, but that they are more sensitive to UVA light than they are UVB light. So it's really important for protecting against those wavelengths if you have one of those autoimmune diseases. But UVA tends to penetrate deeper into the skin. And UVA is the wavelength that tends to cause things like tanning and color change in the skin, but then long-term also lead to things like the wrinkles and aging. Whereas UVB is the one that causes immediate sunburn and redness. So when you're looking at a sunscreen and it's got an SPF of 30, that SPF really only measures the UVB protection. We don't have a current standard or a current measure of how well it protects against UVA. So the best thing that you can do right now, the way that the FDA has regulated sunscreens, you just can look for something that says broad spectrum. And so the reason why most dermatologists tend to prefer physical sunscreen blockers like titanium and zinc is because they protect better against UVA than most of the chemical sunscreen ingredients. Having said that, everyone always asks me what the best sunscreen is. What do you think my answer is going to be?
The one that you use.
Exactly, because it doesn't, I recommend a sunscreen and then people go, that one's too chalky, it's too thick, or I didn't like the smell of that one, or that one's so sticky, it got all over my kid's hair. So I don't really care which one you use. Using something is better than using nothing. But I think the main thing now is the fact that we have these sun protective clothing. You can let your kids swim out there all day long because they've got their wide-brimmed hat on, they've got their long-sleeve swimsuit on, and you're not chasing after them constantly to put sunscreen on their skin. So I think that's why sunscreen, I think, should be sort of a supplemental thing to what you're doing, in addition to seeking shade, not going out in the middle of the day and wearing your sun protective clothing. And then finally, you want to make sure you apply the sunscreen properly. So put it on 15 minutes before you go out, so it's got some time to absorb into the skin a little bit. The general rule is for an adult-sized person, you need 1 ounce or an entire shot glass of sunscreen to cover the entire body. Most people are under applying their sunscreen. And then if you're just sitting there and not doing anything, you're not sweating, you're cool as a cucumber, you still have to remember to reapply every 2 hours. If you're sweating, if you're swimming, if you're toweling off, you got to reapply much more frequently than that. Okay? And then, yes, question?
In general, the discussion about the sun and the implications on scleroderma, is that more for cosmetic reasons, or are there also medical reasons why it might cause this flare?
That's a really good question. So the question is whether or not sun avoidance has a medical implications for scleroderma, or whether or not it's mostly for cosmetic reasons. I don't think there's a whole lot of evidence that sun maybe triggers localized scleroderma or activates localized scleroderma. So in that instance, it's mostly for cosmetic reasons. Okay, and then other side of the thing, dermatologists will say protect yourself from the sun, and then the other side of the healthy skin equation is make sure that you keep your skin moisturized. So the 2 ingredients to healthy skin is using fragrance-free products and daily moisturization. So in general, we dermatologists like fragrance-free products because fragrance can be a very irritating substance on the skin, lead to things like eczema, lead to things like very kind of dry, scaly skin. And so one of the things that I hope to educate you guys about today is how to read a bottle label so that you can recognize fragrance-free. Because you can see these 2 products, they're Aveeno, right? Who thinks Aveeno is a good skincare? Dermatologist recommended, right? You go to the store, you go look at your Aveeno bottles. Which one's fragrance-free? The one on the left. What does the one on the right say? Gentle scent. What does it say? As gentle as fragrance-free. What kind of advertising is that, right? It is so tricky. So you really do want to make sure that you find products that are fragrance-free. We all love, everybody who's got a baby, don't you guys all love the Johnsons & Johnsons? You want them to smell like baby powder? We hate Johnsons & Johnsons. Worst thing to ever happen to baby skin. So fragrance-free all the way. And then we like daily moisturizing creams and not lotions. There's actually some data to suggest that lotions can actually lead to more skin drying because lotions have a higher percentage of water in their formulations. And so we actually think that it can draw more water off the surface of the skin and into the air, causing transepidermal water loss through that sort of wicking and conductive effect. And so moisturizing creams, which, Cetaphil, again, great brand, but head for the creams. Those are usually the thicker, more moisturizing forms in the jar. Okay, so in conclusion, we talked about topical corticosteroids, calcineurin inhibitors, vitamin D, and Imiquimods can sometimes be helpful therapies if you've got mild disease or as supplemental treatment to your systemic medications. That camouflage makeup, fillers, and then sometimes even plastic surgery can be useful if you have inactive disease. I can't emphasize that enough, just like Dr. Torek said. We do not want that being used for anybody who's got active inflammation. And then sun protection and gentle skincare are the foundations of healthy skin for everybody. Thank you for your attention. I'm happy to take any additional questions that you guys have. Question in the back.
When you talk about topical steroids and using them long-term, what's the long-term? Years?
It depends on the strength. So if you've got a class 1 or class 2 topical steroid that we commonly use for morphia, you can start seeing the signs of skin atrophy at about 6 or 8 weeks in some patients. Usually though, by like 3 or 4 months, most people are getting skin thinning. But if you're using a lower strength topical steroid for something else like eczema, you're using a class 4 or class 5, you're not going to see that skin thinning effect unless you've used it continuously for 6 months, 12 months, something like that. And when I say continuously, I mean using it on the exact same spot of skin every single day. So for morphia, that's usually what we want you to be doing, right? Putting it on there every single day on that exact spot. Versus, for anybody, I don't want to get myself in trouble with any of your dermatologists. Like, let's say you guys have eczema. Someone's kid has eczema. A lot of times kids are on eczema for years and years and are on topical steroids for years and years and years for their eczema. But the way that you use it in eczema is a little bit different, right? You apply it to your eczema area twice a day for maybe a few weeks at a time, the eczema clears up, you stop and you set that aside, and then you pick it up again a month later when it flares again. And even though you might be using it for like years in that matter, because you're getting breaks from it, those risks of skin thinning, that's much lower. So don't get me in trouble with your dermatologists. They're gonna be so mad at me if I perpetuated that. Question here.
Are calcipotrate and tacrolimus okay longer term than
Yes, yeah. So the vitamin Ds like calcipotriene and tacrolimus, we use those months and months, years and years because they don't cause skin thinning. So the main thing that we think is that they don't work as well. So they're usually kind of more of our maintenance, long-term therapy for somebody who's perhaps not as active, perhaps has had topical steroids or systemic medications to kind of knock down their disease, and now we're just looking to maintain.
So that's what we were on clobetasol.
Mm-hmm.
I should stop that by like 6 months. I shouldn't use clobetasol.
You should do what your dermatologist or your rheumatologist tells you. But if you haven't seen them in a while and you've been using your clobetasol for 6 months,
We go for And then can I ask, like, what do you feel about evening primrose, SAMI, D3 orally, or those things?
evening primrose, what was the second one?
SAMI,
I'm not familiar with that. How do you spell it?
purple, SAM, and then a big E.
I think it's a sulfur drug, it's like a sulfur.
It's a what? I'm sorry?
I think it's a sulfur containing.
Sulfur containing oral, and then the last one you said was?
D3 oral.
And vitamin D orally. No evidence that I know for evening primrose and SAMI. I don't think there's any specific evidence for oral vitamin D in this disease. So I would say no evidence for any of them.
Okay.
Question there?
I'm just wondering, from your perspective as a dermatologist, what is the point at which there's a lot of people online who have been diagnosed with morphea and are trying to figure out if it's time for them to go see a rheumatologist. A lot of people in America have easier access to pediatric dermatology as opposed to rheumatology. So most days on Facebook, someone posts this to other groups. What would be your sort of, do you have a blanket statement, or what would be your advice on how to define that moment?
I think okay, so the question is, when do you need to see a rheumatologist as opposed to a dermatologist? Because usually it's a lot easier to see a dermatologist. Is that what you're saying?
Yeah, and when do you transition?
And when do you
When
transition?
to possibly even travel to see a rheumatologist?
I think it varies. So I think if you've got circumscribed plaque morphea that's relatively limited, most of those times a dermatologist can handle that, and you probably never need to see a rheumatologist. Am I right? Am I getting myself in trouble here with any of the rheumatologists in the room? Okay, so I would say that's the case. However, I think if you've got linear localized scleroderma, you've got more severe disease, you've got multiple areas of the body, you've got joint involvement, you've got arthritis, some of those other things, then I think you probably should either see a rheumatologist, and in those cases travel to see a pediatric rheumatologist, or you gotta make sure that the dermatologist that you're seeing is somebody who is very comfortable managing those patients, who is very comfortable looking for some of the more systemic type of things. So I can tell you in my hospital, my rheumatologist and I have worked out an agreement where they don't want to see every patient who's got morphea or even linear scleroderma, that I follow all of those patients myself, that I treat them with steroids, that I do methotrexate, but that they only see them and get involved if there's joint involvement or arthritis. But if you've got localized disease that doesn't have, arthritis or musculoskeletal complications. But I think it's different. I think it varies depending on where you're at and the level of comfort of the dermatologist that you're seeing. How do other centers handle it?
I think most patients will go through derm, but actually not ped derm.
Yeah.
You guys only have like us.
Yeah, we're pretty small. So you want.
So I think a little disclaimer is actually you're likely to see a dermatologist, but it's likely an adult dermatologist. I think that's where we need to put our education efforts in, because at least I think historically, I think we could all say the same, is that that's where sometimes you run into someone that doesn't recognize it, or they recognize it, but they
poo-poo your disease. Yeah.
So I think either peds derm or peds room is fine, and a lot of the time there's sometimes combined clinics, so we kind of co-manage together. So I don't think there's a particular answer as far as peds derm and peds room. I think either you're fine. I think it's getting out of the adult dermatologist that's down the street is probably the answer.
Yeah, I totally agree with that. You probably want to be at an academic kind of center if you're seeing an adult dermatologist, is my feeling. Somebody who's probably more in tune with what's going on in the world and what's going on in the research. Question here or comment?
There was discordance among the peds dermatologists on treatment. So
Yeah.
I would agree that an academic
Mm-hmm.
pediatric dermatologist
Yeah.
would be fine, but I don't know if a pediatric dermatologist in private practice that's really not keeping up
Mm-hmm.
with time.
And I don't, yeah, and it's hard to make a blanket statement, right? Because I've got a colleague in my practice who's a premier pediatric dermatologist, internationally recognized, who just told me this week that I don't believe in treating morphia because I don't think anything works. And so I think we just don't do anything. And I looked at her and I was like, I am gonna kill you right now and punch you. Like, how can you say that to me? So, it's hard. It's hard to make a blanket statement, but I think sometimes gut feeling plays a role. Do I feel like I'm getting the right treatment from this person?
I think another thing to think about in terms of seeing a rheumatologist is that we know even with localized scleroderma from Cassie's research that many patients have effects outside of just the skin.
Mm-hmm.
And a pediatric rheumatologist, our appointment times for new patients generally are an hour. We have more time to ask about the other systems in the
Mm-hmm.
body, what else is going on, compared to a dermatologist whose times are often shorter. So even if it's just a one-time appointment with a rheumatologist who you need to wait months
Mm-hmm.
to see, that might be worth it just for peace of mind and to make sure you're getting a thorough evaluation.
Mm-hmm. I think that's a very good point. I think it just depends on, who's doing it, who's managing it, and what workup they're doing. Question over here?
Back from the beginning of the talk, when you were talking about the topical treatments, and you're mostly talking about for the localized kids. Mm-hmm. My daughter has systemic.
Mm-hmm.
Her hands and a little bit on her face, like her skin does feel hard.
Mm-hmm.
So will the softening of the skin, will that work for her as well, or not so much because it's systemic?
Not so much that it's systemic. I don't think there's great studies to have shown that any of the topical therapies work that well. The one thing that I would say that hasn't been studied and I don't think is common usage is Imiquimod. And that's actually something that I'm interested in studying a little bit more to figure out if that does have some supplemental benefit for systemic sclerosis, at least in like certain areas. Question over here?
Fingertips and the blood flow.
Uh-huh.
Have you heard of anything of frankincense or like newer oil,
Mm-hmm.
cypress oil that could be used to help like generate, open up vessels, or maybe help with healing?
So the question is about certain essential oils like frankincense oils that can maybe help with the healing and the ulcers. And unfortunately, I don't think there's any data about that. I think a lot of the things, if you're talking about topicals to help improve blood flow to the fingertips, things like compounded or topical niacin have been kind of reported, and it's something that we try. But also a lot of systemic agents like calcium channel blockers and other things like that.
I just have a general question because, I've been to different adult talks too about just keeping, and the systemics, just like really keeping that skin healthy, getting barriers, like even if it's aquaphor, I know it's, but anything that's kind of really heavy duty is usually helpful.
Yeah.
So as she was mentioning, not like a lotion, like try to even push it to a cream or even
ointment.
kind of an ointment would be best. And I just wanted your opinion. I've been to some of the Scleroderma Foundation meetings, and sometimes they'll have people that have like the beeswax kind of not moisturizer, kind of like the ointments. I felt those to be pretty helpful. Do you promote those? I'm trying to remember their
I think there's like a Dr. Something, right? It's a beeswax based. It's like
there's meta honey,
stuff like
that. I mean, I found my patients who say that helpful. I was just wondering from the dermatology standpoint because it's supposed to have some antiseptic a little bit.
Yeah.
The meta honey.
So I think a little bit, meta honey is like medical grade honey because honey has antimicrobial, antiseptic properties. I think those can be used for like open wounds that you're treating, but they get really expensive and they're not always well reimbursed by insurance. So I would say that the benefits of those might not always be enough to be worth the price. Beeswax kind of based moisturizers are also kind of widely available. And those can sometimes be an effective barrier. I'm a huge fan of plain old Vaseline. So I think in terms of bang for your buck, you can't get anything better than the dollar-sized tub of Vaseline that's that big. Slather on your hands at night. What I really like is something called the wet wrap approach. So like you really slather on the Vaseline, and then you take a wet, warm towel, wring it out, and then wrap your hands in those, and then maybe even take like a plastic bag, like a Ziploc, you know, that you stick your hand in and like pinch it off. And then this is like, sounds really crazy, but you sit there and you watch TV for 30 minutes, and it's like when you go get a manicure, or you like have ever done like a therapeutic body wrap at the spa, that heat and that moisture then helps open up the bonds between the keratinocytes and allows some of the moisturizers to penetrate a little bit better. But you know, I would say Vaseline, and then Vaseline under wet wrap occlusion is very helpful too. I think there's a variety of those, like, you know, just in terms of what works best, it's hard to say, because I think everybody has something a little bit different, and so it's sometimes trial and error finding those various things that you like. I don't know if we have time for more questions or if it's time for the break.
We all good? Well, can you hang around for the break?
I can hang around if people want to come on up and ask some questions, or if there's one more that I'm happy to, yeah.
I'll talk to you in a minute.
Okay.
Okay, she'll hang around for the break, and it's the Sunday break time, so I think the kids are probably already at it out there. You better get to it pretty quickly. We'll resume back in here at 3:30. Thank you, Dr. Chiu.
Thank you.